Well, thank you. Before we move into the program, will you please join me in prayer? Dear Lord, we thank you for the opportunity to receive guidance from those who are here to share with us tonight in planning for our end of life here on earth. We pray our future decisions will be consistent with your will, and our decisions will bring peace to our family and friends. Amen. It's with pleasure that I introduce our guests tonight, and they will be speaking on some very important topics that relate to our end-of-life planning. We have with us tonight, speaking on 5 wishes, Allison Bester-Brewer, and talking about hospice care will be Wendy Van Klinken. Wendy is a licensed practical nurse with chaplaincy healthcare, and Allison is currently working for Prosser School District as an RN. One thing I'd like to add tonight to this program is that a big thank you to these ladies. I know the last 2 years have most likely been very emotional for them with the COVID outbreak that we've had, and they have to work very closely with families, and at times that can be very rewarding, but also very emotional. So let's give them a round of applause. Our first speaker tonight is speaking on 5 wishes, and that is Allison Bester-Brewer.
This is where I need to speak from? Okay. So I know most of you. My name is Allison Bester-Brewer. I graduated from Texas Christian University with my bachelor's in nursing in 1992. I've been working as a nurse since then. I've been in neonatal intensive care. I worked for a group, Allergy Associates. We did research on medications for people with asthma. And I worked in an OB clinic here in town at Pharmacist Clinic. And for the last 15 years, I've been with the Prosser School District as a nurse there. Tonight I'm just reviewing this. I think I probably just know more about this because I got this earlier than you, and so I've been reading it for a few days, but I've highlighted a few things that I felt were important. So if you want to follow along with that, I don't have any slides or program. 5 wishes, to me it is a combination of medical power of attorney, which is something we've heard, a living will, plus it combines your personal, emotional, and spiritual needs along with those medical wishes. I think the biggest benefit of this 5 wishes is it lets you talk with your family and friends and your medical team about how you want to be treated if you become seriously ill. It seems that it is much easier to speak about this before you become seriously ill. Sometimes I think we don't really want to talk about that, but I feel like that's an important thing to do with your family prior to the time when it's needed. So 5 wishes is intended for anyone 18 and older. I think it is a good document because it combines the 2 things that we've heard of, the living will and the medical power of attorney. So I'm just going to move on to wish number 1. And wish number 1 is the person I want to make healthcare decisions for me when I can't make them for myself. And I looked a little bit online. I just did a Google search and this seems to be what medical power of attorney is. So this is about choosing a healthcare agent, someone who, I hear a little feedback, I'm sorry. So the healthcare agent is a person who can help you make healthcare decisions, and this would come into effect when your attending or treating doctor finds that you're no longer to make healthcare choices and another healthcare professional agrees with that as well. This document suggests that you choose, that you have 3 choices for your healthcare agent. And they recommend that you choose someone who is able to stand up for you so that your wishes are followed. And another suggestion is that it's likely that they will be nearby when those services are needed. The people that it should not be is your healthcare provider, an employee or spouse of an employee of your healthcare provider, or someone who is serving as an agent or proxy for 10 or more people. So those are a few things to think about. On the next page, it talks about the decisions. This is actually a worksheet you can use about the things that you want your healthcare agent to help you make decisions about. They can make choices for me about my medical care or services, interpret instructions you've given. So if your instructions aren't clear, that person should be able to interpret those for you. They can give consent to admit to an assisted living facility, hospital, hospice, or nursing home. They can also help make the decision to request or take away or give medical treatments. They can approve release of medical records and personal files. They can move you to another state if you need to get care there. So I'm sure you guys can read those. I'm not going to go ahead and read through that whole list, but this document is meant to either take all those choices, you could cross out those choices. If you have more instructions here that you would like for that person to, that you would allow that person to make for you. So one thing I think to be clear is if you have a medical power of attorney and then you decide to use this 5 wishes. So if you have 2 documents, I think that could be confusing. So down here at the bottom, it tells you to destroy all copies of this part of the health wishes form. So if you change your mind about having a healthcare agent, so you can either cross out and write revoke, or if you have another more paperwork that's about a medical power of attorney, that would need to be destroyed as well, so it's not confusing, so you don't have conflicting documents. And then I'm going to move on to wish number 2, and it's my wish for the kind of medical treatment I want or don't want, also known as a living will. So the person that you name as your medical agent will help interpret your living will and will follow what's written in your living will. So things to keep in mind as my caregiver: I do not want to be in pain. I want my doctor to give me enough medicine to relieve my pain. And these are things, again, you can cross out, you can leave. I do not want anything done or omitted by my doctors or nurses with the intention of taking my life. And I want to be offered food and fluids by mouth and kept clean and warm. It gives a definition here of life support treatment. Life support treatment means any medical procedure, device, or medication to keep me alive. Life support treatment includes medical devices put into me to help me breathe, food and water supplied by medical device such as a feeding tube, CPR, major surgery, blood transfusions, dialysis, antibiotics, and anything else meant to keep me alive. So if you wish to limit the meaning of life support treatment for any reason, you can write that limitation in the space that's provided. One caveat here in the bottom, in case of an emergency, a separate document that might need to be included in your records would be a do not resuscitate form. So that would be something you would need to speak with your medical provider about and have on file. So on the next page, gives some situations about what kind of treatment you would like in these cases. The first situation is close to death, and then all of the options here. I want to have life support treatment. I do not want life support treatment, or I want to have life support treatment if my doctor believes it could help. So those are the choices for all the situations. The second situation is in a coma and not expected to wake up or recover. The third is permanent and severe brain damage and not expected to recover. And then again, space for you to write your further wishes, any other situations you may think of. All right, so I'm going to move on. So those two wishes, the first and second wishes, seem to be more of the medical side, so who you assign as an agent and what your end-of-life care would be as directed by your medical agent. The next three wishes are more on the personal, spiritual, and emotional needs. So wish number 3 is my wish for how comfortable I want to be. And I think these wishes pertain more to your family and to your caregiver. Again, it's listed, I do not want to be in pain. Another option is if I show signs of depression, nausea, shortness of breath, or hallucinations, I want my caregivers to do whatever they can to help me. Third is I wish to have a cool, moist cloth put on my head if I have a fever. So a lot of comfort issues in this list here. I want my lips and mouth kept moist to stop dryness. I wish to have warm baths often. So again, I think these are things that we don't think of every day as providing comfort. Maybe as like mothers of young children who have sick kids, we think of those things, but maybe not towards the end of our lives. Next is I wish to be massaged with warm oils as often as I can be. The next is about playing your favorite music. Personal care like shaving, nail clipping, hair brushing. I wish to have religious readings and well-loved poems read aloud when I am near death. And the last is I wish to know about options for hospice care to provide medical, emotional, and spiritual care for me and my loved ones. So there's no spot on this for extras, but I'm sure if you felt like there was anything else that you have experienced that provides you comfort, or that you have provided comfort to somebody else, that those could be listed and included with this document. Next is wish number 4, my wish for how I want people to treat me. And again, this is like a list you can cross out, add to. I wish to have people with me when possible. I wish to have my hand held and to be talked to when possible. I wish to have others by my side praying for me when possible. I wish to have the members of my faith community told that I am sick and asked to pray for me and visit me. I wish to be cared for with kindness and cheerfulness, not sadness. I wish to have pictures of my loved ones in my room near my bed. I wish for my clothes and bed linens to be kept clean. And there's also a wish here if you want to die in your home, if that can be done. So again, those are things I feel like your family can manage for you with the help of your care providers. And then I'm going to move on to the last wish, wish number 5, and my wish for what I want my loved ones to know. And this one seems to me like it would be good to start on this like today, because there's lots of things in here that feel like could be resolved. I mean, and make your life even richer prior to anything coming along. I wish to have my family and friends know that I love them. I wish to be forgiven for the times I've hurt my family, friends, and others. I wish to have my family, friends, and others know that I forgive them for when they may have hurt me in my life. I wish for my family and friends to know that I do not fear death itself. I think it is not the end, but a new beginning. I wish for all of my family members to make peace with each other before my death if they can. So on that one, I think it's important to start that on like day one, like when you leave tomorrow. So, because you just never know. So, I wish for my family and friends to think about what I was like before I became seriously ill. I wish for my family and friends and caregivers to respect my wishes, even if they don't agree with them. I wish for my family and friends to look at my dying as a time of personal growth for everyone, including me. I wish for my family and friends to get counseling if they have trouble with my death. And then there's the last three are about care for your body after your death. So after my death, I would like my body to be buried or cremated. I think these are probably more common things to talk about. You probably know that about your loved ones. My body or remains should be put in the following location, and the following person knows my funeral wishes. And just a few other sections here about things about after you have passed. So after this document is completed, you can sign the 5 wishes form and have a couple of witness statements. In our state, I don't believe you need a notary of this to be valid. And I'm just going to go through this last page here, what to do after you complete your wishes. So sign and witness a form. Talk about your wishes with your healthcare agent, your family members. Give them copies if you wish. Keep the original copy you signed in a special place in your home. I know sometimes, like on the fridge, my parents have a few forms, not exactly this form, but I know where they are on their fridge. So a location where you know where they are. They do include a wallet card if you wanted to carry that with you. And talk to your doctor during your next office visit. Give copies of this document to them as well. And then if you're admitted to the hospital or a nursing home, ask that this is kept in your medical record as well. And I think that's the end of my presentation. I think we'll have questions at the end, or do we want to take questions?
Is it recognized as a binding legal document?
I believe that the wishes, like wish 1 and wish 2, are the binding part of those documents, because they're very similar to the living will and to the healthcare power of attorney.
Are there any questions or comments? The one thing I'd like to add to her presentation is that, you know, I've been through the experiences with my parents passing away, and they had their wills, but the one thing that was missing, and I thought Allison pointed out well, is that there was nothing in the will about their emotional needs or their spiritual needs. And that's what I really do like about this form, that information can be added. Because when family members are close to death, a lot of times they're not capable of communicating things to you that perhaps they wish they had. So I think this form is outstanding when it comes to that. Any other comments? Has anyone in the room here used this form before?
My sister is a nurse over in Idaho, and she's the one that made my parents fill this out and encouraged all of her siblings to as well. So that's kind of how I stumbled upon it.
All right, thank you, Allison.
You're welcome, thank you.
Wendy? Okay, Wendy Van Klinken will now talk about hospice care.
Yes, it's on. Okay. Okay. Hi, everybody. I kind of waited, but yes, hospice uses the 5 wishes. So I'm talking to you tonight. They asked me to come and talk about hospice care. And for me, hospice care, talking about hospice is pretty exciting. It's my passion as a nurse. I've been a nurse all my life. Over 30 years, I've been a nurse, and I've done all kinds of nursing. And so when I started to say I wanted to work less, I found hospice, and they were looking for nurses. So for going on almost 5 years, I've been their triage nurse. And in the triage, we call it the hub, because you learn a little bit about every aspect of hospice, because we take the calls, we get the nurses dispatched out, we take care of the census. Our hospice, I work for Chaplaincy Hospice out of Tri-Cities. There is another hospice, and that's Heartlinks Hospice, and they're from Sunnyside. So our territory kind of overlaps a little bit, but we all have pretty much the same structure of how hospice works. And so we don't cross over territories usually. Sometimes we do. So we go all the way over to Othello, and on the border of Spokane, so our nurses can travel sometimes really, really long days. But let me back up just a little bit. So what is hospice? You know, when I talk about hospice, it's always important to kill the elephant in the room. It's like people hear hospice, hospice kills. And I like to dispel that, because my experience with hospice has been pretty amazing, because I walked my own father through hospice. And hospice gave Dad a quality of life that I don't think he would have had going to the doctors every week. I asked Dad, I said, Dad, how do you want to live? How do you want to go? He was tired. His body was tired. He was shutting down. And I said, what do you want to do? And he goes, I just want to be with my family. And so hospice allowed him to be with his family, because I had Dad on hospice almost a year before he had his accident, and then we went to the hospital and ended up getting him back on hospice. But what I love about hospice, Allison touched in the 5 wishes, was the spiritual component. And when Dad started getting hospice services at home, that was one of his favorite things. The chaplain came in, and he found out what kind of music Dad liked, and he played some of the big old hymns that just meant so much to him. And he talked about the chaplain visiting and the pastors visiting and the prayer, and that became such an important part of his passage. And it was comfort for my mom, and it was comfort for the family. So hospice is composed of a medical director. So hospice has a medical director who oversees all the patients. Chaplaincy Hospice right now has a census of almost 170 patients. So I feel like I am running an office of 170 patients. It's a lot of work. And we have, I think, 12 nurses. Those nurses are day and night nurses, so there's all kinds of shifts. And then we also have the hospice house. So Heartlinks doesn't have a hospice house, Chaplaincy Hospice does. So what that is a 10-bed, basically an ICU, an intensive care unit. So these are where patients, if they're in home and they're going through pain crisis, and families they throw up their hands and they say, I can't do this anymore. Then we say, would you like to come to the hospice house? So we arrange for transportation to the hospice house, and then the nurses are there 24 hours a day. They get to order what kind of food they want. If they're feeling good, they get to take strolls. There's patios. That was how my dad's life ended. When it came time after his accident, the doctors said, I don't think this is going to be turning around. I asked Dad and I asked Mom. I am their power of attorney. And we had this conversation years ago on how he didn't want life-sustaining anything. And that was very clear. So these 5 wishes are super important, is to discuss this with your family, because there were a few members that I hadn't discussed hospice with. And so all of a sudden when my family heard about hospice, they were like, oh my gosh, no, because that means he's going to die. And I said, we are born, and the Lord gives us life. We live our life, and we die. Death is a part of our life, and it is inevitable. It will happen to everyone. It's just, how do you want that death to be? Do you want that death to be surrounded by your family, by loved ones, by music, by pastors, chaplains, or do you want that death to be, unfortunately, in a hospital with tubes and beeping and running around and things like that? The statistics show that 90% of us will die a long death. We'll have lots of terminal illnesses. We'll have just comorbidities, they're called. So we're going to have diabetes and congestive heart failure and all those things that will kind of just take their toll eventually. So with 90% of the people going through this, it's really important to ask, how do I want to live the rest of my years? And the hospice, the way that hospice is covered is covered under your Medicare dollar. Hospice is nonprofit, so they only take what Medicare will give you. So there's a certain amount a day that Medicare will cover. Your private insurance sometimes has long-term care and hospice coverage, so you need to look into your insurance policies too. When patients don't have anywhere to go, hospice does not turn anyone away. We have hospice patients that are living in the Mission. We have hospice patients that are living in hotels. And so a home or a setting isn't as important as that comfort that they get from the nurses that can come and take care of their constipation, their upset stomach, their allergies, their end-stage problems that they have. And end-stage is a lot of pain. When you have patients that have cancers and different cancers, the pain that cancer gives is horrendous. The brain tumors, and you can go on. Chaplaincy hospice comes in and delivers comfort measures. Those comfort measures are usually medications, and there's all kinds of different medications. Patients come to us from their doctor or the hospital, and they have a list of medicines this long. And a lot of times, if you have decided you're done going to the doctor, I am so tired of going to the vascular surgeon and the podiatrist for my feet, and the list goes on. And in our Western culture tries to keep us young longer. So there's all these professions that have just tried to keep us young, tried to keep us healthy, but when you have decided that enough is enough, then hospice comes on board and says, what's important to you? So we sit down with our patients and we find out family dynamics. We have the medical director, then it's the registered nurse who goes out, or we have licensed practical nurses that can also get out into homes. And then we have social workers. So social workers are a huge asset because social workers know all about the rules and regulations of what needs to be filled out, who's your power of attorney, who is your medical durable power of attorney, who, and kind of walks through the family and says, if this is the scenario, how can we help you? If they're working with the Department of Labor or the VA, then the social workers will help them file all that paperwork and get it to where it needs to go. So they are huge assets for our patients. So that's pretty awesome. We write a lot of letters for patients that are terminal so that they can get coverage under their insurance plans. And that's all just a part of what hospice does, because the social work part of hospice is pretty crucial. And then we have chaplains. And those chaplains are responsible for going out to the patient's home, and they pray with the patients. We have some patients, they absolutely say, I don't want a chaplain visit. And we say, fine. So nobody is held to any, you have to do this or you have to do that. It is strictly on what does the patient want? What is going to help you get through what you're going through? So chaplaincy is, we can sign people up if the doctors say, looks like you have 6 months or less. But don't let that fool you, because the certification periods for hospice have to do with Medicare guidelines. So the certification periods are 90 days, and then 90 days, and then every 60 days. And we have patients that are on 29 certifications. So 6 months, 29 certifications is a whole lot longer than 6 months. But what happens is every one of those certification periods, the doctor has to do a face-to-face visit with that patient, and he has to decide, is that patient still going downhill, or is that patient climbing up? And if the doctor looks at them and says, hey, you're out and about, you're going to dinner, you're doing this, you're doing that, and driving around, how about we get you off of hospice for a while? And then we go through a discharge of that patient. That doesn't mean they can't come back. That means they want to live their life more. They climbed out of it. We've had people with cancers that looked like they were dying, and then they kind of climbed out of it, and they like, I don't want hospice anymore. And we're like, good. We have other patients who we sign them up with hospice, and then all of a sudden they panic, and they want to go back to the doctor for treatment. And we say, okay, that's fine, because then they have to just go through a revoke. And so what a revoke is a piece of paper. And that's what we had to do with my dad. You know, when Dad fell and he broke all of his ribs, it was more than we could handle at home. And we did put him in the hospital. But all the doctors wanted to do was just pump him up with the pain medications, because that was the only thing that we could do to make him comfortable. And so I talked to Mom, and I talked to the family, and we have the hospice house, and I said, we were forced to look at, Mom couldn't take care of him at home, so the caregiving piece is huge. You need to know who your caregivers might be. But we had the hospice house, and I said, Mom, it's either a facility, some of your long-term care facilities, or we can choose the hospice house. I said, Dad is tired. He is done. He wanted to go home. He kept saying, I'm ready to go home. And you know, hearing that from your loved ones, if they are ready to go home, then you need to honor their wishes, and not by pumping them full of meds or hanging IVs and being in a noisy hospital. I said, Daddy, we're going to take you to the hospice house. He was like, okay. And what was beautiful is that, and I promised I wouldn't cry, but anyway, what was beautiful was that they were pretty lax with us. We had our whole family in there. At one point, probably too many. I had to tell everybody to be quiet because there were other patients at the hospice house. And we closed the door. There was the patio. We could open the patio. And we were able to sing Dad's songs. We were able to pray with him. We were just able to sit by his side. And watching someone die is probably one of the toughest things you'll ever do. And I don't know if anyone has been with someone who's died, but it's a pretty tough road. But one of my precious, precious memories is with, hospitals. Through the COVID, that was one of the other issues. That was really strict. When we were going through that, they didn't allow a lot of visitors in the hospital, and we were like, how can someone die if they can't even get visitors? So that's really a stressful point too. So when Dad was at the hospice house, his very last visit was his 2 little great-grandsons and my daughter, because Mom and I had already gone home before Dad passed. And Daxon and Bo, they held Grandpa's hand and sang, Jesus loves me. And so those are things that you might not get in a hospital if visitations are restricted. And so, but the teamwork of the hospice group is pretty dynamic. There, we get calls, a day and night. And when a patient calls and they're having a pain crisis, we have comfort kit medications, and we walk them through those medicines. And I'm able to tell them on the phone, okay, go and get your kit. This is what you have to take. And then we'll get a nurse dispatched out there. So there's also part of hospice through the Medicare dollar is durable medical equipment. So that medical equipment is a hospital bed, an over-the-bed table. They have commodes for the bathroom, shower chairs, oxygen, and all of the durable medical equipment is part of what hospice pays for through that Medicare dollar. So when you sign up with Medicare, there are a lot of medications that are not deemed necessary, and those rules are changing. So it's an ebb and a flow of trying to learn, okay, what are we covering since Medicare changed all their rules, and so it's kind of a hit and a miss with not hit and a miss. It's a going by what Medicare rules are that we say, okay, today this is what we have to cover as Medicare, as hospice physicians. And so I fill out all the forms for unrelated medications. There are medications that aren't related to the primary diagnosis that you get onto hospice with. So say someone has lung cancer. Lung cancer begins the number one primary diagnosis. So with lung cancer, the primary diagnosis, they're probably not going to pay for your fungal medicine for your toenails. Does that make sense? So a lot of those medicines then are billed to your private insurance or under a Medicare Part D plan when they see, and we have to supply all that information. So we have to supply the Medicare D, medicine part of Medicare. We have to supply them a total list of all the medicines that we're paying for and not paying for. And that's part of what I do in the office as well, is go through all of that for every patient. There's a lot that, there's a lot of aspects to hospice that probably I'm forgetting. My notes are not here, but I pretty much covered the team, the group, the nurses, the doctors, the chaplains, the hospice house. So maybe you guys have some questions for me? Yes. Okay, the question is, what triggers a hospice for the patient? And Dick, it's different for everybody. Most of the physicians at all the major hospitals, that's where all of our referrals come from, but you can refer yourself. So most of the hospitals, when the doctor decides, these are your choices. There's palliative care. Palliative care is something that you can still keep your own doctor, and there's a palliative program that is for people that are in the end years of their lives, and it's another layer of doctoring for you. When palliative is no longer something that is acceptable because you're like not getting out of the house anymore and things like that, then the doctor may say, we have done the last cancer treatment, we have done everything we know how to do, and now it's time. For my dad, a couple years before we had Dad on hospice, one of the doctors at the hospital, he pulled me aside and he said, there's not much else we can do. He's just living life. And I said, I know that. And he said, how many times does he want to come back to the hospital? And so that was really a slap in the face. I thought it was really hard to hear. But I said, I understand that, but there's a time when a patient needs to go to the hospital. They need to go out to that emergency stuff. So when the emergency is over and you're starting to assess, then the doctors usually will be the ones to say, have you thought of hospice? But we have patients that they got a diagnosis of a glioblastoma, which is a brain tumor. and they have given them, you might live 6 months, you might live a year, it might take you in 2 weeks. And then they are given the choice to decide. And the patients that we have had on, then we cover the nausea, the vomiting, the pain, things like that. So with the pain medications, one of the things that people are really, really scared about is the word morphine. But one of the things that I learned with working with chaplaincy and seeing it myself, my first day at hospice, I had 2 deaths. I had 2 patients die, and that was my very first day. And so watching someone die and seeing what happened when we used the morphine acts as a muscle relaxer for the lungs. And so when patients are in their end stages and they're dying, they're struggling, they're fighting to breathe. And so that medication relaxes the lungs enough to where they're not fighting and not struggling. And then they're more calm, and then you can talk to them. Some of the patients, they ask for palliative sedation. Palliative sedation is enough medications to kind of just keep them zonked out, basically, because that's how they want to live the rest of their life. So you have a choice. But yeah, Dick, that was a good question, because every scenario is different. But we have people that call on the phone and say, I want hospice care. And so then our team goes to work. We get medical records from the hospitals, the doctors. We start going over their medical records, and we see, do they qualify? What would be their qualifying diagnosis? And so that's a huge part. It's an investigation. So, any other questions?
So Wendy, maybe you can review this. I'm sure you spoke to this. But what happens if a patient is not old enough to be under Medicare? How is that handled?
So we do have patients that are on private insurance. And so your private insurance plans usually have a hospice benefit that they don't really talk about. But our social workers at that point, they will work with you. If you've got, it kind of depends on your economic status too. Because if you don't have Medicare, you have insurance, there's no benefit, then it becomes a daily rate of what it would cost to be on hospice services. So, you had a question back there? Yeah. Yeah. So that's a really good, I'm glad you brought that up, because it depends on what your support system is in the home. And we at hospice have to be really careful. One of the first things that I have to do when I answer the phone is I have to get into the patient's chart, and I have to see, who did they want me, who did they allow me to talk to. So that's called a HIPAA. You've all heard of the HIPAA, which is the Privacy Act. So I have, for instance, a patient who's dying and struggling to breathe, and I don't have anybody that's trying to talk to me on the phone on the Privacy Act, and I say, I can't talk to you. I need to talk to somebody who you've allowed. I have before taken information from them and dispatched a nurse as soon as we could so we could get relief to that patient. So we have to be really, really careful with that. I have patients that call and they say, hey, I heard that Joe Blow is in hospice house. How's he doing? And I said, well, I'm sorry. What's your name? And you have to research that before you can say anything. And I've had pastors call and I said, I'm sorry, I cannot give you that information. So that's a really important part. But with the medication, there's giving medications in the home is a real job. And I admire families to have their paperwork, and every 2 hours they're getting this medication, every 4 hours they're getting this medication, and that's what's keeping that patient comfortable. So families are who I admire, because they're at home, they're with loved ones, And it's pretty awesome. And when you can be a part of that end process for your loved one, it's pretty special. So yes.
Yeah, this is just a comment. You were talking about these services. My husband had problem with neuropathy of his feet and everything. There was a massage therapist that came out.
Pretty sweet, yeah. And we have nurses that will do toenail care and physical therapy and things like that. So mind you, physical therapy is not usually one of the hospice criteria, because with hospice, it's like you're not trying to go through physical therapy. But what we do is we do some therapy just to get an evaluation. So we'll do a swallow evaluation, because part of end stages of dying are a patient gets what's called dysphagia. So it makes it hard to swallow. It makes it hard to, take any food in. And so when we know what we're looking at, then it helps us with the right kinds of medications or softer foods, or know how to tell the family, this might be what they want that they'll not choke on. And being able to instruct the family how to give medication through a syringe at the back of the mouth, and turn a patient from side to side when their lungs are filling up with fluid and they can't breathe. And so those are all things that the chaplaincy hospice nurses will help walk you through. And so with being available 24 hours a day, there's always a nurse that will call you back and find out how they can either assist you on the phone or send somebody out to the house. So, Dick.
How does hospice coordinate with a long-term care plan?
I'm sorry, what?
I said, how does hospice coordinate with a long-term care plan? Is that a concern?
The long-term care benefit is something so new that it hasn't really been defined yet. They haven't even taken it out of our paycheck yet, because there's so many differences. But I know people do have long-term care insurance, and so I don't know how that works. I have to be honest with you. I've never looked into that.
Because I know mom was in assisted living, and she did have a long-term care insurance plan, but we also have hospice coverage.
Right. Well, so your long-term care then aids in part of the daily cost and stuff to stay at a facility. And so this is one of the things that we didn't have for Dad. And so we were looking at, hundreds of dollars or thousands of dollars a month to go into a facility, versus, hey, Dad's got VA dollars and he's got Medicare. And that's why we put him in the hospice house, because you can stay in the hospice house for however long you want to. And we have patients that go to the hospice house, get their problems taken care of, their pain under control, and then look for a place to stay. And so the goal was to bring Dad to the hospice house, see if he got better, see if he could kind of pull out of that, so we could take him home, because I was thinking about maybe quitting and working with Mom, with Dad, but the Lord had other plans. So, but yeah.
Is most of the country covered with hospice? Or is there spots that aren't?
There's spots that are not. Hospice, though, is pretty widespread. One of the interesting points, I'm glad you asked that. One of my jobs also is to do contracts. So we have hospice patients, like out of 170, and we have one patient who he's doing good enough, and so he decides to go to the races every month. There's car races somewhere. So we have to do a contract. We have to find another hospice in that area so he can travel, because when you're on hospice care, you go from one hospice to another hospice. So if something happens when you're there, our nurses don't have to go there. Their nurses come to see you. So that's a pretty cool part of being on hospice services. From all of the hospices, I have probably a catalog of 20 different hospices within like California, Oregon, like Seattle area here. So there is quite a few hospices. So it's kind of nice and we have patients that travel and come here to see loved ones. And so we have to make sure they don't need oxygen, make sure their medicines are covered. We have their medical records. And so we download all their records into our computer system so that if our nurse gets called, then one of our nurses can go see them and have a little bit of their history of what's going on. We had a lady just recently that came to Benton City, and she came to see her family, and then she passed while she was there. So it's nice to have that hospice support. Then it's one of the biggest things I can say about hospice is the teamwork and the support and the comfort and the peace that it brings family.
My mother went into the nursing home, she was on a medication that cost $650 a month. And because of the social worker, knowing all the different companies within Medicare Part D, she was able to get my mother into a program that, if I remember right, was like $50 or $60 a month. So social workers are very, very valuable, and we need to take advantage of those.
Amen. Our social workers do a lot of work, so it's pretty awesome. And we still do. I get patients that are on certain medications that they want prior authorizations for, and so if it is a medicine that the doctor deems that, yeah, they should be on that, and their Medicare is not paying for it, then I'll do a prior authorization and get it covered so that we can have it for a certain amount of months. So there is a lot of things that we can do, and it's not all you go into hospice, you have to forget all your medicines, you're not going to do that anymore. But in all reality, when the body is shutting down and you are, say, diabetic, well, with diabetes, it's like one of the things that is important is regular food and regular insulins. Well, if somebody's not eating, they're not going to be needing insulin. So the medicine kind of dwindles down as a body starts to shut down, and they start taking medicines away that aren't your statin medications for your cholesterol. They're not going to do you any good at the end of life. A lot of those things are taken away because they're just not what is important anymore. So, yes. So Chaplaincy Hospice is completely nonprofit. We do a huge fundraising. The pamphlets in the back tell you a lot about hospice, and the year thing that I left, it was the winter one. But they do a lot by donation, and that's how we run. We also have Cork's Place, which is for children of grieving, like their mother or father died, and we walk children through the death process, and we have specialists that go through that. We have the Repeat Boutique, and so the Repeat Boutique over the last several years has become more and more important, because what's happened is patients, kind of like, I'm looking at all of mom's stuff that's not going to fit in her house anymore because we've downsized. It's good stuff. It's like, what do you do with it? So Repeat Boutique has a truck, and they will come to your house and they'll pick things up that you want to donate. And so those dollars then go toward hospice care. So, and they do apply for grants, and they apply for this to run off of. And mind you, I appreciated the prayer and the thought of nurses, because during COVID it was really tough. We had so many nurses walk out that the nurses were just, double and triple booked, and it was a really tough time for us. So we're starting to climb back out of that. We have a new medical director that's going to be coming on in July. His name is Dr. Watson. better not say that. I don't know what's, anyway. He used to work at Trios, and he finally took the job full time. So we had 2 doctors in the last year retire. And so both of those 2 doctors have been with us forever. So it's been a struggle to just like pull out of that as well. So, but we'll move forward. So we've got a lot of people on the team.
I was surprised when I had Tom and everything that I got, no bills, no anything. I realized we had Medicare, but then we also had a secondary. But I didn't see anything in paperwork.
And that's the goal. You,
I know that they went through because I could see in the computer, but that was very helpful.
And that's the goal with hospice is to complete that out and do the bereavement part. So hospice has a bereavement team that comes in at the very end when a patient passes. And so that bereavement team and chaplain are supposed to reach back out to the family and make sure everything was done. Did all your questions get answered? And even the social workers, we have husbands that their wives did all the banking for them ever, and the husband's going, I don't even know how to write a check. So we have a team of volunteers that go in, and those volunteers will sit with people. They'll help them walk through that. So there's pamphlets back there that talk about volunteering. There's pamphlets back there that talk about the process. So help yourself to all of that. And, yeah, we're always able to answer questions. Yes.
Tom was in during COVID, and I was wanting to do that. Somebody to come and sit with me for an hour and a half while I ran around and did some chores. But COVID, they weren't allowed. I don't know. My girlfriend's husband's also. He came on and visited.
It was really sad. COVID hit us all. So whole COVID did take all our volunteers away. I used to have a whole bunch of volunteers that came upstairs in my office and did a lot of work for me, and they were no longer allowed in the office. And, we just a week ago, they finally let us give our masks away. So it's been a trying couple of years. It's been a lot of work. And we're kind of climbing back out of things that kind of pushed us down a little bit, but we're getting there. So I'm still excited about hospice, and I'm glad to be working there.
I learned one thing from hospice. If you fall, you don't want to call 911, you call the fire department.
What's really important to know is that. So, and I've taught my mom that. So all of the fire departments have a non-urgent medical. You just say, this is non-urgent, but my father fell, my mother fell, can you come and pick them up? They will come, they'll dispatch a team out, and so I get a lot of those calls. I get a lot of calls of patients falling at home and the spouse can't get them up, or their kids, and so I dispatch the non-urgent team, and they head out there, and they're basically almost on the road before I ever get off the phone with them. And then they'll call back, and then we'll send a nurse out and make sure that the patient wasn't injured or anything like that. But yeah.
The nurse came in, because I called, because I couldn't get him out of the chair to get him to bed.
Mm-hmm.
And 2 of us couldn't get him out, so she said, leave him there.
Yeah. Yep.
Our surprise is,
Keeping them comfortable with blankets and pillows and
picked him up and put him in there,
yeah.
did everything.
Yeah.
They had a intern, and the nurse said, yeah, you go ahead and do all the stats.
Yeah, so they are very, very important, and they're really sweet. They go out whenever you call, so that's really nice. But yeah, yes.
Whenever my husband died, he got up out of the bed sometime during the night, and I got up and found him on the floor. So I called hospice, and I had covered him up. They dispatched the ambulance. They came, they picked him up and put him back on the bed until other people could get there.
Yep. And that's really important for when you make that call, let the team know that my loved one is on hospice. Because if they are, they'll call the hospice nurse. They'll call me at the office and they'll say, hey, what do you want us to do? And I'm like, is there any injuries? And then we walk through this process. We send a nurse out, and they usually just take care of them at home and don't send them to the hospital. Some patients have chosen to go to the hospital, and then we revoke, we sign paperwork, and they get shipped off to the hospital. And then most of them come right back onto hospice, which, you know, is not something that we tell them that they can do, because there's a waiting period of how long you can, you know, go. It's illegal to say, hey, you can be on hospice, we'll take care of you, and then if you want to go to the hospital and get this treatment, you can, and then we'll bring you back. That's illegal. And so we have to be really super careful with that. And that's why everything comes down to signing a form and saying, no, you're on hospice, and that's it. So there's lots of legalities that you have to take into account. But yeah.
Are there any other questions or comments? Allison, thank you. Wendy, thank you very much. Appreciate it. And Bonnie, next Thursday is